So next patient is a young 23 years old male, past medical history of asthma, presented with dysphagia and chest pain with regurgitation for 3 years. Initial OGD showed moderate amount of food residue in the lower esophagus, and an HRM done in another hospital in September, which showed an integrated resting pressure of 51.6, with DCI of over 8,000, 100% premature contractions, and tracing showed presence of peristalsis. 24 hours ambulatory pH study showed a acid exposure time of 0.1, the MESA score of 0.7. Subsequently, had a CT showed dilatation of the thoracic esophagus with abrupt transition at the GOJ. No suspicious mural thickening at the point of transition or along the esophagus. So he was referred here for POEM initially, but subsequently the HRM was reviewed and did not appear to be atypical of type 3 achalasia. Here are the images. The plan today is to have a repeat HRM plus or minus OGD plus or minus Endoflip. The operator today is Dr. Marc Wong.
Hi. Hello, can you hear us?
Yes, morning.
Hi, welcome, and so we have a full motility team in Peterbridge. That's me and Jacky, and we are happy to have excellent nursing support, Garling and Lok Yi. So also we need to thank the patient for coming and to repeat the procedure, and so we actually, in the interest of time, we already intubate the HRM probe. And we actually run a couple of swallows, but we'd like to demonstrate that to you as well. So maybe the camera can focus on the screen, which is essentially the real-time HRM topography. So essentially, I understand that HRM is not readily performed by all the gastroenterologists, but I'd still like to show you some very important thing. So essentially, the #1 rule for doing good manometry is to make sure the probe did traverse the LES, and essentially that has gone into the stomach. In some cases, for example, in achalasia, and it can be difficult because first of all, the LES could be a little bit tight, and sometimes in cases like type 1 achalasia with substantial food impaction, it can be very difficult to traverse and negotiate the HRM probe across.
So Marc,
yes,
not everybody here is familiar with HRM. Can you go slowly, like how do you put in the probe? Is it under endoscopic guidance or?
Okay, thank you. Yeah,
and
sure.
And you mentioned it's very important to cross the lower esophageal sphincter. So
yes.
how can you make sure it has been done?
Yes. Thank you. Very excellent question, and essentially the #1 rule. So HRM probe is a very soft catheter. So maybe the camera can show a little bit. It's a very thin catheter. So we have two types, but essentially the diameter is probably about 3 to 4 millimeter. So this is something called solid state catheter. So patient would be awake, and they will be given some local anesthesia through the nostril, either the left and right, which side doesn't really matter. And then the patient will intubate the probe inside into the patient while the patient is awake. Usually, the most part that causing discomfort will be when it traverses the nasal pharynx. And then we ask the patient to perform active swallow when actually it goes through the UES, which is the pharynx, then the patient actually don't really have to swallow. Then we gradually intubate further the HRM probe until we see usually, so maybe we can focus on the HRM monitor again. So basically, HRM is a measurement of pressure. So we have a graph, probably with some anatomical landmark that can help us with the understanding. So this is the more proximal part. This is the upper esophageal sphincter, and this is the esophageal body, and this is the lower esophageal sphincter, which, as we know, the sphincter are usually in tonal contraction. So in terms of the pressure, they will show us as a persistent, what we call pressure band. And the reading...
allow me to interrupt again.
Yes.
So that means the probe, it's go in blindly, basically. But since it is so soft, particularly in tighter achalasia or even sometimes sigmoid esophagus, how would you handle if the scope doesn't, if the probe doesn't pass through the achalasia smoothly?
Okay, so the question is how to make sure...
I think Prof. Song is asking about the difficulty in
placing the probe in hyperplasia cases
Oh, yes.
for various reasons, as Marc mentioned before. So I think in our daily
Jason, your voice is not well heard. Yeah.
Okay, do you hear me? Yeah, I thank you for your question. So essentially, we rely quite a bit on the tactile feeling. We insert it essentially a little bit like when we insert rice tube for tube feeding. And usually, but here we actually we are helped by the manometric tracing. Usually we expect, and very importantly, we want to correlate with the clinical suspicion. For example, in case of achalasia, we do expect the LES band to be quite prominent. So, but actually the insertion really requires some tactile feeling. When we go to the marking that we expect the LES to be, sometimes we require a little bit of twisting, and sometimes it's very difficult. We ask the patient to drink some water, and then help to kind of transport the catheter down. But there will be cases that we need endoscopic guidance. Essentially, we would put in maybe an OGD or even a nasal endoscope through the mouth alongside alongside the catheter, and we can use some forceps to grip the most distal part to try to put it down into the stomach.
So in difficult cases, you do need
in
a
difficult
scope
cases, but fortunately, with experience, usually we do not require that.
Okay.
Yes, so here I'd like to show you, if possible, can we zoom in a little bit more? If not, it's okay. So there are two pressure bands, a little bit high up, yes. This is the UES band, and if we can ask the patient to swallow, so we ask the patient to perform what we call a dry swallow. We see when the patient swallows, the upper esophageal sphincter actually opens. And that's actually a propagation of contraction from the upper part of the pharynx down, which because usually we want to demonstrate better of the lower esophageal sphincter, some part of the LUS is not shown. And lower part is the lower esophageal sphincter. So actually, sometimes when for achalasia case, some distal obstruction, sometimes the probe cannot actually go through the LES, and then it will actually loop. It will loop back up such that there is a bending of the catheter, and it causes false reading that we thought it actually went through the lower esophageal sphincter, but actually it has not. It can be very tricky. So how to make sure that it has indeed gone through the LES into the stomach is we rely very heavily on the change in the respiration. So actually, if we know the esophagus and the stomach are situated in the different parts of the body, the esophagus is in the intrathoracic compartment, which when we breathe and we inspire, the pressure will actually become lower. And the stomach is in the intra-abdominal compartment, which when we inspire, because the diaphragm flattens, the pressure will be a little bit higher. So we rely very heavily on the change in the respiration to make sure that the catheter actually did traverse the LES into the stomach. So now I'll ask the patient to deeply inspire. 唔該，大啖吸一啖氣。Okay, we still zoom in, please. Yes. So here, we ask the patient to inspire. You can see the part in the esophagus. Actually, the color will become a little bit more blue, a little bit more calm. So essentially, it show a drop in the pressure. And then we see the part below the supposedly LES, the pressure become a little bit higher. So we show that this is not a falsely kinked catheter, but actually it had indeed traversed the LES into the stomach, and actually the diaphragm flattens, so the pressure over the LES is actually a little bit more prominent. So now we will proceed to perform something we call wet swallow. So we will ask the patient to swallow 5 ml of normal saline. So Jacky, thank you.
口含住，
好，
吞一啖啊。
So as a part of the standard protocol, we ask the patient to swallow 5 ml of normal saline, 5 ml of fluid, but we want normal saline because we also measure something called impedance, essentially electroresistance. So normal saline has some electrolyte, so it maximizes the reading. So maximize the result. So we can see, despite the patient did initiate a swallow, there's opening of the UES, there's total absence of any discernible contraction. And then the LES, usually we have to rely a bit on eyeballing at this moment, but when we analyze the result, we can have some reading. The LES doesn't seem to be relaxed very completely. So, so actually this complete one swallow, and we ask the patient to perform another swallow. So I've always been asked, so how do we interpret the manometry? Sometimes they show us one swallow. I have to say, usually going back to so-called Chicago classification, we basically would not recommend making a diagnosis based on a single swallow. We have to use at least 10 wet swallows and analyze everything together. But here, I can tell you, we performed a couple of swallows previously, and all the readings are the same. So we can see, actually, focusing on the swallow, there's a total absence of peristalsis with apparently absence of LES relaxation as well. So if all the 10 readings are the same, this is actually a type 1 achalasia. So the reason why we actually want to repeat the exam is, although the previous examination in other hospitals showed type 3 achalasia, apparently premature contraction is exceedingly rare. And actually, it didn't show a very typical finding of the location of the pressure band, so we felt the need to repeat the exam.
So Mark, here we see a vertical pressure band. Yeah. So can you enlighten us how to differentiate between a retching and a panesophageal pressurization?
So essentially, if panesophageal pressurization, that is a squeezing of the esophagus, the pressure band would stop at the LES. It would not extend beyond to the stomach. The patient was kind of having some a little bit of retching, a little bit of a nausea sensation, which is very expected because the patient, we see the patient would supposedly have a lot of fluid retention. So sorry, Prof. Song, do you have
can you remind us what is type 1 and type 3 achalasia?
Okay, so maybe Jacky can supplement a little bit.
Sure. Thank you, Prof. Song, for the question. So essentially, achalasia is a disease characterized by failure of LES relaxation and also failure of esophageal peristalsis. So we classified it into 3 types, type 1, type 2, and type 3. They are characterized by different peristaltic pattern. For type 1, it's a total absence of peristalsis. For type 2, it's characterized by panesophageal pressurization, in which patient need to have at least 20% out of the 10 wet swallows of panesophageal pressurization to be classified as type 2. Whereas for type 3, it is a distal esophageal spasm type. So by this, we mean we measure the 10 wet swallows, and if the patient have at least 20% of distal esophageal spasm, defined by the distal latency of less than 4.5 seconds, then the patient is said to have a type 3 achalasia. This is important because it may have some implication on the treatment. In particular, because POEM is nowadays the first line of treatment. If the patient have type 3 achalasia, it is shown that POEM can achieve a longer myotomy. And actually, if we deliberately make a longer myotomy during the POEM procedure, it may have a better outcome for the patient.
So Jacky, in this very young age group, which would actually be the most prevalent type?
Well, actually, I think in our locality, type 3 is exceedingly rare. We almost only see maybe 1 to 2 cases in the past several years.
Yeah, I have to say we probably don't have a very good local data, but we are seeing a lot more and more achalasia. It also depends on at which stage we diagnose the disease. If we diagnose early, when the esophagus still retains more peristaltic function, we probably see more type 2 and type 3. But sometimes, because we know achalasia may be a spectrum of disease, sometimes if the area obstruction is persists for a long time, because of chronic obstruction, the esophagus would actually lose part of its peristaltic function, and they will progress into type 1, and even in very severe cases, dilated megaesophagus. So I think the true incidence of the type of achalasia is still probably unknown. So actually, going back, even now we are diagnosing something called EJG outflow obstruction, which is we see some obstruction at the LES level while the esophagus still retains some peristalsis. But if the diagnostic, for example, manometry or even endoflip is very suggestive, we do proceed with definitive treatment like POEM.